Good morning, everyone. I am not going to rap, but I'll try to make it interesting. I think my name tag is migrating. I think that was a great talk to set the stage for what I'm going to talk about, which is really information that a lot of you have because this is the information you've given us over our first year as a foundation. I'm going to tell you a lot about what we've learned in the process of forming as a foundation and the work that all of you told us you want to do, particularly as it relates to the information we heard this morning about how you sort of begin to turn a $3 trillion ship in a more productive, valuable direction. So just for the background, for those of you who don't know who the Montana HealthCare Foundation is or how we came about, we were formed at the end of 2013 through the sale of Blue Cross and Blue Shield of Montana pursuant to the state's conversion statute. Just about every state now has what are called conversion foundations. These are foundations that are formed when a nonprofit health system is sold or sometimes converts to being a for-profit health system. The proceeds or the assets at the time of the transaction are taken and put in a private foundation. In our case, we started with an initial $40 million contribution that came from the proceeds of the sale of Blue Cross and Blue Shield of Montana to HCSC. And we're now up to about $100 million of assets. We're a permanent foundation. We'll make grants of about 5% of the value of our corpus per year. We'll, in addition to grant making, we'll do research, we'll do policy work, we'll contribute our own staff's professional expertise and convene discussions and provide whatever we can, whatever we have in the bank to support improving the health of Montanans. So just a quick timeline to give you a sense of where we are. As I said, the transaction came about at the end of 2013. The board was formed in 2014. They did a search and hired me in October of last year. So we're now just a year into my time with the foundation. We made our first grant in 2014 through a strategy that the board had developed, and I kind of put the finishing touches on. This was basically a grant that has gone to support county and tribal public health departments to collaborate with their communities, with critical access hospitals, with other elements of the health system to do community health needs assessments, community health planning, and health improvement initiatives. This work is in progress, and we'll have more to tell you about it probably next year. Very exciting, though. I think one of the things we learned, for example, is that health departments have to do community health assessments. Critical access hospitals do community health needs assessments. We've now got, I think, at least 7 or 8 counties collaborating with their community, with their critical access hospitals to do these together and strengthen the work and save some resources in the process. We did a lot of work to do our first strategic plan to really understand what are the needs out there, what are the good ideas for improving Montanans' health, and to develop good partnerships around the state as well. And we issued our first open call for proposals in April of this year. So just a little bit about the way we approached developing a strategic plan. We felt it was very, very important to have a real and intimate understanding of the needs around the state. I spent an awful lot of time digging through all of the data sources I could find to understand health, not just sort of through state level statistics, but really at a county or community level as well. We've met with many of you and many other stakeholders around the state, tribes, elected officials, hospitals, hospital associations, other professional associations, nonprofits, and so on. Really learned a lot, and I think also looked at how other conversion foundations similar to us in some way, whether it's size or the type of state that they work in, are doing their work and what's been successful. We came away from all of that with 3 very broad areas of focus. The first is what we call behavioral health, and that's a fairly intentional name, partly because one of the things we heard is that the care system and reimbursement structure for mental illness and for drug and alcohol addiction are very separate, somewhat fragmented. and both in great need of support. One of the surveys I remember was from a series of critical access hospitals, almost every one of which put help with drug and alcohol addiction treatment at the top of their list of needs. So we are focusing on integrated behavioral health, putting those two together and integrating them better within the rest of the care system. Second is American Indian health. I don't think that it's news to any of you that there are health disparities in this state that affect tribes and urban Indians. We also heard a lot in getting to know the tribal health system about just basic administrative challenges that where, if you run a hospital, you probably kind of take the coding and billing part of your operation a little bit for granted, or you know that that's the engine that keeps you afloat, where tribes really struggle to sometimes to even with the basics of the business of healthcare, and therefore can't build a stronger health system that better addresses their community's needs. Partnerships for Better Health we made intentionally as a somewhat broad and vague bucket because we really wanted to stay as responsive as we could in these first few years to understand, to learn more through grant making what people need, what's going to work. But we do have a focus there, and I would, increasingly, particularly based on the response to this first call for proposals, put this in the value-based bucket in a couple of ways. First of all, when you work in rural Montana or rural Alaska, where I practiced for years, you realize you're dealing with scarce resources, workforce challenges that are very, very pernicious and difficult to fix. So how can you use those resources that you have more wisely? How can you actually work through better partnerships, through better collaboration, more intentional planning to use what you've got better and more efficiently and more effectively? So in our first call for proposals, what happened? What ideas did people have around Montana for ways to address the problems that Nate did very amazing job of outlining at a national level? Well, it turns out people had a lot of ideas. It was an amazing response, in my opinion, to a first call for proposals. We had more than 154 letters of interest, or I'm not sure if more than, we had 154 letters of interest, about $7 million of requests. We got 62 proposals under that behavioral health umbrella, 24 on American Indian health, and 68 under the Partnerships for Better Health bucket. This is just a quick summary of our funding criteria, and I encourage all of you to visit our website if you want to learn more about the specifics. But really, we emphasized, first of all, places where there's a demonstrated need, serious health problem, serious need, and an unmet need. We really looked for innovative ideas, things that have a potential to transform not just the local health system, but also to be replicated by other communities around the state. A focus on projects with a sustainable business model. We really were cautious about funding grants where we would be starting new programming that depended on our funds and didn't really have an exit strategy at the end of that 2 years. So things that would be reimbursable potentially through third-party payers, or through some sort of a shared savings agreement where it was clear there would be a mutual benefit generated that would sustain the project after our grant is over. Again, we were pretty hard on people about partnerships. We didn't want a list of organizations you already work with. We wanted specificity on how you're going to do something new with a new partner. We focused very much on practical Montana-relevant work. We did not fund organizations outside of Montana. And we intentionally looked for a breadth across the state. So we didn't just fund in Bozeman, where we're housed. We didn't just fund in the big cities. We tried to find organizations around the state that wanted to do this work with us. This is just a quick map of where we ended up getting proposals from and making grants. Pretty good spread around the state. And ultimately ended up funding 34 new projects. So I'm going to spend some time talking about the grants that we made, because I hope they'll get your juices flowing, get some good ideas out there. Hopefully you'll like these ideas and have more yourself. But I also just wanted to point out that, as it was pointed out very vigorously to us in the first hour this morning, there is change. And the context of this call for proposals is change. And a lot of it is this sort of value-based language. I mean, in the Health Act itself, we're supposed to provide greater value for the tax dollars spent and reduce healthcare costs through new things like care coordination and outcome incentives for providers and reducing readmissions. The SIM grant, which is anyone not familiar with the SIM grant? This is the CMS State Innovation Model Design Grant, which is, we've had it for about a year in the state, but the work is really just getting going in the last couple of months, talking again about how to redesign the health system through multi-stakeholder collaboration to improve health outcomes and control costs. And then, of course, things like the Patient-Centered Medical Home Initiative and Medicare changes that all of you are intimately familiar with, which is really, again, the context for all of the work that you proposed to us to do. A couple of key challenges that we really ended up focusing on in what we funded. First is just the need for integrated care. Mental illness, more than 50% of us are likely to be affected by it at some point in our lives. It is the leading cause of medical disability, one of the leading drivers of healthcare costs. And of course, if you have an addiction and you have mental illness and you also have diabetes or high blood pressure, it gets more and more complicated to get the care you need, and that's the wrong direction. So we focused on the need to better integrate the care. We heard a lot about drug and alcohol use, and if you think about how those drive healthcare costs, you have to think way beyond treating drug and alcohol abuse. You have to think about the downstream consequences, trauma and DUIs, the hepatitis C, the poorly controlled chronic illnesses. The fact that in Washington State, for example, I think 90% of their patients that they labeled super utilizers had a substance abuse disorder as one of the diagnoses. And then also just my least favorite term in all of medicine, the social determinants of health. Least favorite because it takes the common sense, it's so wonky, and it takes the common sense out of what I think we all know to be true if we think about it for a minute. Healthcare is not health. Healthcare is not the same thing as, having healthcare is not the same thing as being healthy. And many factors outside the doctor's office influence health outcomes and the outcomes of care. And how do we address that? What in the world is the health system going to do? I love this. This creeps into a lot of my talks now. This is out of Yellowstone County's combined Community Health Needs Assessment, Community Health Assessment, and it shows, it's maybe hard to see, but in purple are low-income patients, middle and high-income in the tan, and just a whole range of things that people self-reported. So skipping visits to the doctor, skipping doses of medications, far more likely if you're low income. Can't afford to buy healthy food, much more likely, of course, if you're low income. Poor mental health, considerably more likely if you're low income. So how do we begin to address those outside influences? How is the health system going to improve outcomes? We're going to have to think about this. This is one of the factors that we'll have to address as we start thinking about value. So I'm going to spend the next part of the talk taking you through some of the ideas that organizations out there, probably some in the audience today, had for ways to begin addressing these issues. You actually heard Nate mention briefly the idea of community paramedicine. If you think about a rural community, what healthcare professional is sitting around doing this for any part of their day? Not very many. But if you have paramedics in your community who may be waiting for an emergency, is there any way that you can use some of that time productively and valuably? We had an idea from Glacier County EMS to partner with the hospitals and the health department to do home observation and emergency room and hospitalization follow-up for vulnerable patients. If you're worried about somebody, it's awfully nice to have something you can do to get some follow-up at home. The idea of Promotoras, so the Community Health Partners, which serves Park and Gallatin counties, serves a very isolated, very high-risk Latino population, and they'll be providing lay health education and outreach to this population through training lay people from the community. Barrett Hospital is Critical Access Hospital, which is getting engaged in a rural accountable care organization. We'll see how it goes. We decided it was worth helping them get engaged in this pilot because it's the first time that's been tried in Montana. I talked about social determinants of health, and very interesting proposal from the Montana Legal Services Corporation in collaboration with the Primary Care Association to place public service lawyers in community health centers to help patients with things you don't necessarily think of law when you think of health care, but if you really think of unsafe housing, family violence, denial of senior benefits, and so on, this can be a real asset to some of the most vulnerable and probably some of the most costly patients. So again, we'll be piloting this. This will be a lawyer that works with a network of community health centers. Manufactured housing and replacement. So I hope I'm not boring any of you who've heard me talk before. I can almost never find a way not to talk about this example. And when I was a first-year resident doing a rotation at Children's Hospital in Oakland and admitted I think a 5 or 6 year old boy for his third admission in a month or two for very severe asthma exacerbation, we did not do a root cause analysis, but we did do extensive chart review and convened a team to look at why does this kid keep coming in so sick. He's got a very smart mom. She was able to demonstrate exactly how his medications were supposed to be given to him. It appeared that the care had been appropriate. His doses of asthma medication kept being escalated, and he just would not stabilize when he went home. His mom lived with him in a tiny, very old apartment with mold on the walls, rat infestation. Not a pretty place to have to try to manage an asthmatic. So I asked the attending physician, can we prescribe renovations, a new apartment? Prescription pad didn't work that way. Prescription pad still doesn't largely work that way, and yet we know that in some cases those conditions outside the hospital and clinic are some of the big drivers of healthcare costs. Think about how much each of those admissions costs versus some subtle, small home repairs perhaps really making the difference. So we're having a new collaboration with NeighborWorks of Montana and local hospitals to start looking at ways to finance and address the health risks created by substandard manufactured housing. The RSVP program, this is a senior volunteer program from the Rocky Mountain Development Corporation. They apparently demonstrated a substantial reduction in readmissions for frail seniors when discharged from the hospital in Helena. They're now expanding this program to do to rural hospital. And then, again, on a very different level, the problem of neonatal abstinence syndrome or drug withdrawal in newborns is increasingly recognized in Montana as a big issue. Hospitals that deliver babies around the state are dealing with it, but there's not a lot of standardization. Again, we heard a clarion call this morning for the need for standardization in care, and this project will, with Kalispell, which is a big referral center for these babies, is going to be working with hospitals around the state that deliver babies to develop standards and protocols for their care. Under behavioral health, we heard a tremendous amount from organizations around the state about their desire to work on integrated behavioral health implementation. So one example of a pilot that is going to be an implementation pilot is Holy Rosary in Miles City, collaborating with the Eastern Montana Community Mental Health Center to put behaviorists in the primary care clinic and primary care doctors in the mental health center. Well, this is a complex effort it's not a huge grant. It's very ambitious, and we're very excited to see whether what the result is of this. Does it cost more? Does it actually cost less? Does it improve outcomes? And what are the challenges? What are the real practical challenges of beginning to share patients in that way? We have a lot of organizations interested in beginning to plan and getting training, so we're going to be providing training to a number of the facilities run by Western Montana Community Mental Health Center, Beaverhead County, the Center for Mental Health as well. One that's not on here, but I think as long as we're talking costs, I should have put it on. It's a great example, is Helena. Helena's, I believe it's the county health department and LAC are going to be working on what's called a sequential intercept model. This is where you bring everybody who tends to touch the mentally ill and people with addictions in a community to the table and look at where these people are entering, whether it's corrections, whether it's mental health, whether it's the school system, and look at where they're engaging and what you could do to actually save money and improve outcomes through a more coordinated, systematic approach. So they'll be designing a behavioral health system. We've heard a lot about the problem of drug use in pregnancy, so not just caring for the newborns who are born addicted, but giving better, more comprehensive, more integrated, team-based care for moms who are struggling with addiction during their pregnancies. St. Luke's and St. Vincent have grants to begin developing an approach to that. We are funding some planning for a psychiatric residency. We have one of the lowest numbers of per capita of psychiatrists in the state, and certainly a need. And we are doing some work in telepsychiatry with North Valley Hospital, which is going to be looking at providing telepsychiatry in a couple of schools and a nursing home. The last set of grants that I'll talk about just briefly is on American Indian Health. And just some examples there with Rocky Boy, where we gave them a substantial grant to work on developing a centralized coding, billing, and revenue capture system to really strengthen their business, the business side of their programs, and hopefully put them on more stable footing for designing their health services. They have an amazing team. They've recruited some very experienced people who've recently come back to the community after spending a long time working professionally out of Montana. An injury prevention program on Northern Cheyenne. Injuries are very prevalent in Indian country. This is going to be an evidence-based approach to injury prevention. This is a program that the Indian Health Service often funds, but Northern Cheyenne has not managed to get a grant from IHS, so we'll fund a startup and hopefully put them on good footing to pull in some funding to continue it later. Health insurance enrollment and utilization. The Confederated Salish and Kootenai tribes, which are really an amazing operation, very sophisticated healthcare system run by the tribe. They're going to focus on a couple of things. They're going to take over the last bit of services that the Indian Health Service currently provides on the reservation from the IHS, run it tribally, and they're going to focus on getting people enrolled in insurance, whether it's Medicaid or other third-party payers. We are funding a couple of efforts on school-based health services. We really think this is an exciting approach to getting high-risk, vulnerable kids care that they need in a place where they're very much more likely to access the services. So Blackfeet, as well as Bighorn Valley Community Health Center, will be starting school-based health services. And then recruitment and partnerships within Montana. And telemedicine at Fort Peck. We gave them a small grant, and they have a very ambitious set of goals to really explore how to build a more robust and complete health system given the recruitment challenges that face them and other rural Montana communities. And then a needle exchange at Fort Peck. Needle exchanges are an interesting thing if you think about the costs of treating a single case of Hep C, and you think about how hepatitis C is transmitted. You realize that these are a fairly low cost, potentially very cost effective solution to improving outcomes and saving money. So just a few conclusions. We learned a ton from all of you and others who applied for our grants about what can be done to improve value in Montana's health system. Medical care is obviously expensive, no doubt. The costs are rising. There are lots of factors outside of our control that can affect the outcomes that we're trying to achieve. We cannot get it all done in a 15-minute office visit. We have to think more creatively than asking doctors to do more and more and more in those short visits. It's clear that value-based approaches are new and evolving fast, and there's not yet a lot of data on what works and what doesn't, either to improve outcomes or to reduce costs or both. I think the way to think about our foundation is we're a resource for adaptation and we're a resource for leadership. If you have ideas on ways to do business differently and better, if you have ideas on ways to improve patient outcomes without breaking the bank, that's really what we're here for. $100 million is a lot of money, right? So if you break down the I hope I'm doing my math right, if you break down the $3 trillion or the almost $10,000 per patient, you come out with somewhere in the neighborhood of $10 billion a year spent on healthcare in Montana. We're a catalyst. We're not a funder of programs. We're not going to fund some program that's going to, completely change the game in Montana, but we can fund pilots that we hope, a few of them will succeed, like venture capital. We'll have a few great ones that get across the goal line, and everybody else looks and says, that's a good idea. That's what we're here for. And we are growing, though. We'll be implementing a whole new call for proposals in 2016, hopefully a little bit earlier than April, and we'll be giving away more money next year. Urge you to, if you are interested in being part of what we're doing, join the mailing list, and of course our door is always open. We're happy to talk about your ideas. Thanks.
We have time for a few questions. I see one right there. We'll bring the microphone over there to make sure that everybody can hear your question.
I may have missed it in your talk, but my question is, on studies like the ACO at Barrett's, will there be a time when that information will be available on the internet for the rest of us?
Absolutely. So all of these grants are, of course, in their first month just getting off the ground. But we at one component of every one of these projects, whether it was a $10,000 grant or a $100,000 grant, and that's about the range, is evaluation. So we've asked the applicants to propose a small-scale self-evaluation. We'll certainly put every important outcome that happens along the way on the internet. We'll talk about it as much as we can, and as we build our own kind of staff capacity, and as our grantees begin seeing results of the projects, we will talk about them on through our channels. Yeah.
Other questions? Well, I know we're going to have a lot more opportunities for this kind of work in the future with foundations in the state of Montana assisting with healthcare. But we would like to thank you, Aaron, for giving us our first glimpses of what to expect in the future.
Thank you. Thank you very much, Anna.